Disorders. Over to
Good noon, everybody. And at the outset, let me thank Dr. Joshi and Dr. Venugopal for inviting me for this talk. This is my building, Department of Neurological Rehabilitation in NIMHANS in Bangalore. So we'll be talking about rehabilitation in Parkinson and other movement disorder. So initial 15 to 20% we'll devote about Parkinson's disease diagnosis and other Parkinsonian features. And then we'll focus on the rehabilitation issues. Right? So how do you define Parkinson's disease? So it's a slowly progressive neurodegenerative disease characterized by fixed inexpressive face, what we call as the mask-like face, tremors at rest. Everything is important. Remember, tremors at rest is a basal ganglia feature. Otherwise, you may have tremors because of a lot of other reasons. Slowing of voluntary movements, gait with short accelerating steps, and peculiar posture, and this is happening due to basal ganglia region, and because of the it is affecting the neurotransmitter dopamine, right? So although we consider it as a motor symptom disease, but it has a lot of non-motor symptoms which antedate the motor symptoms, and we will be discussing about them in the subsequent slides. So how do you diagnose Parkinson's disease? Again, this is according to UK Parkinson's Disease Society Brain Bank criteria. So you have to have bradykinesia, generalized slowing, associated with rigidity, resting tremors, again are very important, and postural instability, which may come later on in the patients of Parkinson's disease, but Parkinsonian disorder, you will find it appearing much early in the course of illness. And then you have to have three supporting features like unilateral onset. If you are seeing the patients onset bilateral rigidity, bradykinesia, consider something else. It could be a Parkinsonian disorder, not Parkinson's disease. Persistent asymmetry up to 2 to 3 years, then it becomes bilateral, and that's how we define HNY staging and pull test. All those become significant. So it starts unilaterally, but eventually it becomes bilateral illness, right? Resting tremors. And the patient should have excellent response. You will see the patients coming in the OPD, a lot of them are taking levo plus carbidopa. Patients are giving partial response, but in Parkinson's disease, patient has to have dramatic response to levo plus carbidopa. So patients, most of the symptoms improve. That's when you call it that, yes, the patient is having idiopathic Parkinson's disease. And of course, it is a progressive disorder. And levodopa response, and later on you may find patients developing dyskinesias. And clinical course of 10 years or more. Let's skip this, we will go to the next slide and discuss. So what are the alternative diagnoses? Where you are having patients who are having bradykinesia, who are having rigidity, but tremors, mild or no tremors, particularly absence of Rett's tremors, then you have to consider the pathology is not basal ganglia, somewhere else, cerebellum or somewhere else. Severe bradykinesia, just like lower body Parkinson, which you find in vascular Parkinson's disease, where the patient's having rigidity, severe bilateral lower limb. So the diagnosis, your neurologist would write lower body Parkinson's disease. So it is not Parkinson, it's Parkinsonian disorder, vascular Parkinson's disease. Severe symmetrical signs and rapid progression, again not a sign of Parkinson, but Parkinsonian disorder. Postural instability, gait difficulty and freezing at onset or within 3 years of, again you have to think about something else, not Parkinson's disease. And falls at presentation, which you will find probably in Lewy body dementia, corticobasal syndrome, PSP, but not Parkinson's disease. So then you have to think about something else. And then there are slowing of saccades and supranuclear palsy, again which would be there in PSP, other than the normal elderly population. 15% of the elderly normal population would have up-gaze restriction. And dementia preceding motor symptoms, again you have to think about Lewy body dementia or probably PSP, where subcortical dementia appears in the course of illness. Hallucinations, again more you would be seeing in the corticobasal syndrome, Lewy body dementia. And severe and symptomatic dysautonomia, again you have to think about multiple system atrophy, which is a Parkinsonian disorder, not Parkinson's disease, right? So this I have made a table just to tell you about the common Parkinsonian disorders, and these are all hypokinetic disorders. In the next slide we will see what are the hyperkinetic and hypokinetic movement disorders. So this is about the Parkinsonian disorder. So idiopathic Parkinson, we know what happens, bradykinesia, rigidity, postural instability and tremors are there. Whereas drug-induced Parkinsonism, so of course the history will tell you whether the patient is having Parkinson's or drug-induced Parkinsonian. Patients who are taking antidepressants, taking antipsychotic medications, patients who are taking metoprolol like GI prokinetic drugs. So these drugs can also induce what we call as drug-induced Parkinsonian disease, right? Multiple system atrophy, again the patients would have these features, but patients could be MSA-C or MSA-P. P means Parkinsonian predominant, C means cerebellar predominant. Multiple system atrophy, and a lot of patients, probably up to 1/3 of these patients would present to you as autonomic dysfunction. How? Dizziness, blood pressure is dropping, digestive issue, heart rate variation is there in these patients, bladder control is not there, urinary symptoms, patient presenting as urinary symptom onset, and you would consider, a lot of elderly patients do develop idiopathic overactive detrusor, so you can't ignore that. You have to work up the patient, look for other signs so that you can make the right diagnosis. Progressive supranuclear palsy, I have quoted this study, which is Prashant L.K. Yeah, so this is Prashant L.K. Prashant, who is our alumnus in NIMS. He has just reviewed this article. This came probably last week. And talking about the progressive supranuclear palsy, he has reviewed this article. That is the reason I wanted to point it out. And what happens in PSP patients? Rapidly progressive disorder. Parkinsonian features are there, which are rapidly progressive. And of course, you have vertical gaze, the restricted range of motion is there. Patients would have bradykinesia, poor control, falls early in the course of illness. Speech and swallowing difficulty, dementia happening early in the course of illness, then you have to think about Parkinsonian disorder, not Parkinson's disease. Same with the corticobasal syndrome. As the name suggests, you would have pyramidal features. Patients would have trouble in controlling limbs. Jerky movements will be there. Spasms will be there. Speech involvement would be there. Swallowing difficulty. And of course, you would find dementia early in the course of illness. Same with the Lewy body dementia, which is more common in males as compared to females. They would have hallucinations. So visual hallucinations in the course of illness, patients are reporting. So then you have to consider RBD, rapid eye movement sleep behavior disorders. Again, so you have to think more about the Lewy body dementia, memory issues. So all these issues would take you away from Parkinson's towards the Parkinsonian disorder. Vascular Parkinson, again the patients would have history of multiple stroke, multi-infarct state, small vessel disease in the MRI, and then these patients would have clinical features of rigidity, early onset slowing, memory disturbances, lower body Parkinson's disease, illness occurring as bilateral symmetrical illness, predominantly involving lower limbs, and very poor response to levo plus carbidopa. Then you have to probably think about vascular Parkinson's disease, right? Then there are hyperkinetic and hypokinetic movement disorders. What are the hyperkinetic movement disorders? Like excessive and involuntary movements, all like you are having dystonia, you are having myoclonic jerks, you are having tics or tremors. So all these are known as the hyperkinetic movement disorders, whereas the hypokinetic disorders, where patient is having akinesia, hypokinesia, rigidity, bradykinesia, difficulty initiating movement or freezing, which is again a part and parcel of most of these disorders, right? So this is a very important diagram just to emphasize on the fact that although we call Parkinson as the motor symptom disease, but non-motor symptoms are equally important. They antedate the motor symptoms. As you can see in this Bragg stage, motor symptoms start when already stage 3 is passed of Bragg stage. So the illness is starting in the enteric plexus or olfactory bulb, cranial nerves. Patients are having hyposmia, constipation, depression, even 10 or 20 years before the onset of motor symptoms of Parkinson's disease, right? Then the illness goes into the locus ceruleus, brainstem. Once the illness is there in the substantia nigra, that's when you start having motor symptoms of Parkinson's disease, right? Then it becomes, Hayan and Yar stage becomes important. Stage 1 is when the illness is unilateral, tremors, rigidity, and akinesia. Once the illness becomes bilateral, we call it at HNY stage 2. Stage 3, pull test becomes positive, patients start having poor balance, and that's when this becomes a stage 3, and illness is probably already 10 years or maybe less. And then you can see the patient, there is involvement of prefrontal cortex, temporal lobe involvement. Stage 4, HNY stage, patient starts having falls, dependency and cognitive decline, and stage 5, a patient is wheel or bed bound or wheelchair bound. The treatment, we know, we will just spend a little time in this. The treatment, earlier we used to think, let's spare the best medication for the later on. Let's try to treat the patient with salicyline and rasagiline or dopa agonists like ropinirole or pramipexole. But now the Theory has changed. If you want to give quality of life to the patient, the moment you are convinced the patient is having Parkinson's disease, straight away start with levo plus carbidopa, syndopa or syndopa plus early in the course of illness to have better quality of life as well as regression of the symptoms. Late Parkinson's, the patient would be having drug-induced dyskinesias. So what do you do during those during that time? Probably amantadine is one of the drug of choices for that, 100 to 200 mg. Or what you do, levo plus carbidopa, you dissolve in water, give suboptimum doses multiple times a day. Instead of giving it 4 or 5 times, probably you can give it every 2 hourly, 7 or 8 times a day, suboptimum dose just to control the dyskinesia. And if the patients are not responding to this treatment, then probably you have to go for the deep brain stimulation, which is now becoming more and more common. A lot of movement disorder doctors are doing deep brain stimulation. But there are all candidates are not ideal candidates for deep brain stimulation. It's a very costly procedure, 35, 40, 45 lakh rupees procedure. So the patients who have shown adequate response to dopaminergic therapy, presence of fluctuation. So we are saying it is good for Parkinson's disease, not Parkinsonian disorders. Age less than 70, dyskinesias, patients are having resistant tremors and reasonable cognitive function. So those are the ideal candidates for going for deep brain stimulation. We do not want to do it on the patients who have not responded to levocarbidopa, who are 70 plus, so their mobility, any age-related mobility has gone down considerably. They are already having dementia, so they will not be good beneficiary of this deep brain stimulation. And what are the nucleus areas we stimulate? Subthalamic nucleus, which is most commonly stimulated, thalamus and globus pallidus. Right, now coming to the rehabilitation issues in these patients. Issues are related to posture, gait, balance, falls and fear of falls, loss of independence, depression, cognitive impairments, and urinary. Some of the features which you would come across during the rehabilitation of these patients. So let's start with gait. So gait, what happens in Parkinson patients? Difficult weight shifting or initiating movements, reduced arm swing, as you may have seen this Vladimir Putin when he was walking with moving his one arm. So the Western world had told he is suffering from Parkinson's disease, it's gone advanced, but no, it is because of his military training, he always walks with swinging only the one arm. So that's how the Parkinson patient, unilateral onset, would be swinging only one side of the arm or reduced arm swinging there at least in the initial stage. And then short steps, as you would find in a lot of neurological disorders, short stepping, hypokinesia, increased time with double stance, again you will find in a number of cases with neurological disorders. Episodes of freezing probably in Parkinson's disease would come later, in Parkinsonian disorders it may happen early. Turning en bloc, because of severe rigidity, instead of doing the segmental movements, patients are having en bloc movement in these impaired balance, again which would happen later in the course of illness, Parkinson's disease. So this is typical gait in idiopathic Parkinson's disease. You can see the normal gait. You have a fixed base of support. Patient step, stride length is almost symmetrical. In early Parkinson, you can see the narrow base of support. Steps are becoming shorter and shorter as the patient continues to walk. Whereas in the advanced stages, it becomes asymmetrical. Patients are having an even narrower base of support, short step, short stride, and probably cadence increases in some cases. In other cases, cadence also comes down. So this is a study which is just comparing the gait, doing the gait analysis with patients who are having Parkinson or Parkinsonian disease. Look at the gait speed. In a normal person, this is the gait speed, but it has gone down in the patients of PD. MSA patients, it has again gone down further as compared to Parkinson's disease, and PSP also is the same effect. Same holds with the stride length. The patients are having good stride in a normal person, and as compared to this, Parkinson patients would have shorter stride length. MSA would have even small stride length, and we know how the patients walks, forward stooping gait, fascinating gait, always trying to catch their gravity. So they are walking slow, the short stepping and striding, so the cadence increases. But in PSP it doesn't happen because they have poor balance, tendency to fall, so they walk very cautiously. So in the PSP patients, even the cadence would also come down, right? So cadence. So what are the strategies in some of these issues? The patient's cueing strategies were very important for the patients who are having freezing of gait. Dual task, you may have seen a number of papers on dual task training of these patients. But cueing is very important. Auditory cueing, like asking patient to do left, right, left, using metronomes, music. So metronome would induce sound after every 3 seconds or 4 seconds, and the patients would accordingly walk. So that would help in improving with these auditory cues. The gait becomes better. Visual cues, like you have seen, you can see this is the mat where we have made the footprints, and patients are asked to walk on them. So the patients tend to walk better and less likely to fall with this kind of training. You can give tactile cues also and cognitive cues. Right, so this is one study which we published long back. This was a randomized control trial with a very large sample size, 60 Parkinson patients. We divided them into 3 groups, and conventional only medication, conventional gait therapy, and body weight support treadmill training. And the outcome measures used were UPDRS and its subscores, and gait was measured with 2 minutes of gait treadmill walking at 10-meter walk test. And what did we observe? We observed significant improvement in UPDRS scores, gait parameters in both CGT and PWSST, partial weight support treadmill training, but between the two, partial weight support treadmill training patients tend to do better after 4 weeks of training. There was one Cochrane review also about the role of partial weight support treadmill training in Parkinson's patients, and this is, I think, old Cochrane review, 2015, 10 years ago, which included more than 600 participants. And they concluded, based on the studies included, treadmill training may improve gait speed and gait stride in these patients with Parkinson's disease. Coming to the balance, PD patients have dyssynchrony of leg muscles during movement, so they tend to have poor balance in all Parkinson and Parkinsonian disease. This is again our study which we did with the force platform Biodex against 60 patients of Parkinson's disease divided into 3. And the outcome measures were POMA and POMA Trinity scale and Berg's balance scale, other than the force platform where we check the limits of stability in all directions. So what did we observe? PWSST group had a significantly better UPDRS scores, balance indices, limits of stability in 8 directions, and there was improvement in the POMA in their balance. And compared with CGT, the partial weight support treadmill training group had a significantly better UPDRS score, motor score, and mediolateral index. So these patients tended to do better as compared to the patients who were taking only medication and not indulging into any training. So this is some of our work. I will not go into the details. This is some of our work with the PSP and gait training of the patients. Falls. So the PD patients who had fall within the last 1 year are likely to fall again, right? And most falls occur during the transfers and freezing of gait. So we have to focus, or the rehab team has to focus more on promoting active lifestyle, giving them active exercises, which could be aerobics, which could be resistive exercises, which could be strengthening exercises, and cueing strategies. So all these strategies probably improve falls in these Parkinson patients. Right, so this is, in fact, this Allen group, if you see a lot of publications from the same group, they had published earlier also, Intervention for Preventing Falls in Parkinson's Disease, and this particular review is 2 or 3 years old. So they did the systematic review, and they included a good number of patients, more than 3,000 patients, 32 studies. Out of that, 25 studies focused only on the exercise intervention in preventing falls. 1 study was 3 studies focused on the pharmacological intervention for prevention of fall, 1 study with education, and 3 studies with education plus exercise. And what did they observe? Exercise intervention reduces the rate of falls, so exercise do have a positive effect in preventing falls in these Parkinson patients, and slightly reduced number of people falling with mild to moderate, not in advanced Parkinson's disease. Cholinesterase inhibitors, which are usually given when the patients are having cognitive impairments like donepezil and rivastigmine, it may also reduce the rate of falls, but you have to weigh whether the drug is more effective, drug-induced sedation which is causing falls versus patient's illness per se is causing the falls. So that you have to weigh and take a call. What are the benefits of exercise in Parkinson's disease? There are a lot of benefits, as you can see. It reduces the risk of developing PD. It enhances the effect of medication which you are giving, and it therapeutic benefits of the Parkinson's disease. It improves the motor symptoms like bradykinesia and gait training, and it improves the non-motor symptoms also, like cognitive, sleep disorders, mood disturbances, and sensory abnormalities. All these, exercise has multipolar effect in affecting a lot of impaired areas in case patients with Parkinson's disease. This is another study which is talking about the patients, Parkinson patients who are active versus the patients who are inactive. You can see the patients who are doing moderate physical activity and severe, more rigorous physical activities. The all-cause mortality is much less in the patients who are active as compared to the Parkinson patients who are inactive, not indulging into the physical activity. So again, this emphasizes the importance of physical activity. Continue to remain physically active if you want to avoid this mortality or prolonging the life. This is a consensus statement. This paper is published last year from a UK group, I think Queen's Square London group, and they have published multidisciplinary rehabilitation in PD. What are the roles of therapists and what is the role of assistive technology? So as you can see, the role of occupational therapists, they divided the patients into upon diagnosis, early PD, mid-stage PD and advanced PD. So the role of occupational therapists, again the roles will remain same, but you have to do periodic reassessment just to see if there is any deterioration. So like occupational therapists will be doing ADL assessment, functional ability, fine motor hand controls, talking about the fatigue, talking about the driving patient, does the patient have driving ability or not. If the illness is advanced, then we are talking about the environmental adaptation at home or workplace, how the patient can be given a fall-safe environment where the patient can work optimally. Again, the role of physiotherapist, like doing aerobic exercises, resistive exercises, and then doing the reassessment again for the balance and gait training, and then again focusing on the home safety, advising the modifications at home at the workplace. And the assistive technology, using walking aids, memory aids, night lights, dressing aids, electric toothbrush and razors, and powered wheelchair, etc., depending upon the level of injury and the patient's functionality. So this is a Cochrane review published last year, physical exercise for people in Parkinson's disease, and this included close to 8,000 patients in their review, all patients with mild to moderate disease, not advanced PD, who had no cognitive impairments, and the authors concluded that there are beneficial effects of exercises in preventing falls, maintaining quality of life, and keeping them active. Coming to the urinary symptoms, and we have published our work with the Parkinson's disease and PSP in the patients who are having urinary symptoms. This was published long back, probably 7 or 8 years ago. We included patients with PD and PSP who were having urinary complaints, and the main urinary complaints we found were majority of the patients had nocturia, urgency and urgent continence, and some would have mixed bladder pattern also, like retention of urine or involving both. And then the UDS finding may found more than 50% of these patients had overactive detrusor with or without dyssynergia, whereas some patients had normal detrusor pressure, and some of them in fact were found to have acontractile detrusor, which you cannot correlate anatomically, but that's what we have seen in a number of illnesses. So it does not correlate with the anatomical lesion. Right? So this is our paper which is under consideration. This is only patients with MSA, multiple system atrophy, and our patients had MSA cerebellar in 21 patients, MSAP Parkinsonian in 6 patients, predominantly male. And as I told you, MSA patients, a lot of them present with the urinary complaints. But in our study, we found only 4 out of 27 patients had urinary complaints at the beginning of illness. So that the reason was most of our patients were the MSA-C, not MSA-P. So that could be one of the reasons for this. That's what we have argued in our discussion also. So you can see 4 patients has urinary symptoms appearing before motor symptoms. 7 patients had motor symptoms preceding. In fact, 16 patients had motor symptoms preceding the urinary symptoms. So what were the urinary complaints? Urgency and increased frequency, incomplete. So it's a mixed bladder. There is no definite pattern. Nocturia is important, retention, straining to void. So you cannot correlate with the level of lesion. These patients would have mixed kind of bladder. And what did we find? Close to 80% of the patients, as compared to PD and PSP, where 50% of the patients had overactive detrusor. Here in this particular cohort, we found 80% of the patients had overactive detrusor, with or without DSD, and 6 patients had acontractile detrusor. Virtual reality, there is a Cochrane review which says there is low quality evidence. Virtual reality can help you in improving the gait, balance, and quality of life in these patients. Same with the TDCS. They check TDCS whether we can prolong the on stage with TDCS and cut down on the off stage of the PD, and they found low quality. Yes, it has some impact in improving the on stage. Cognitive impairments are common, but it happens later in the course of Parkinson's disease. So remember, here we are talking about Parkinson's disease. So risk factors for PD dementia. So PD dementia is different with dementia with Lewy body and other things I told. So PD dementia happens late in the course of illness, right? So the patients would have minimal cognitive impairment. Advanced age is another risk factor. The patients who are developing Parkinson's disease in advanced stage are likely to have dementia early in the course of illness. Older age of disease onset, limited cognitive reserve already. So patients suppose already having senile dementia, MCI already there, so they would tend to have dementia early in the course of illness. Patients who are having hallucinations or predominantly gait disorders, all these patients would tend to have PDD, right? So what are the some of the most common? Executive dysfunction, attention deficit, visuospatial functions, and processing speed are some of the most commonly reported features of dementia. The clinical measures which we use in our OPD practice is MMSE or MOCA or PD cognitive rating scale, Addenbrooke scale, and we of course our team uses immense neuropsych battery also. So there is emphasis. How much time do I have? 2 more minutes. Okay, I'll run fast, right? So the non-pharmacological measures do tend to increase the cognition, as is true with the normal population also. If you are doing a lot of physical activities, aerobic exercise, strengthening exercise, that does tend to improve your cognitive impairments also. Some balance exercises, nutrition and vitamin D, etc. So that would help. And of course, if the patients are going into mild to moderate or moderate cognitive impairments, you can try cholinesterase inhibitors like donepezil, rivastigmine, memantine, etc. Let's skip this slide. This is a paper published last month, again talking about the assistive technology in the patients to prevent the falls. We'll skip this paper. Psychiatric disorders are common in these patients. Depression, as I told you in the Braak stage slide, up to 50% of the patients of Parkinson's disease would have depression at some point during the course of illness. And the more risky is female sex. Patients who are already having history of depression or family history of depression, they are more prone to develop depression. And patients who are having early onset PD. And of course, management will remain the same, SSRIs, SNRIs or TCAs. Anxiety, again up to 40% of the patients, and it could be anything. Anxiety, generalized anxiety disorders, panic attacks, anything can happen with these patients. And management, of course, the medication profile will remain the same other than benzodiazepines like clonazepam or alprazolam, etc. Psychosis, hallucinations is common, and untreated patients' hallucination is even more common, right? So the medications, again, quetiapine we believe is the safest drug because it has minimum extrapyramidal side effects. All other medications would have extrapyramidal side effects, so quetiapine probably the safest drug. Impulse control disease, again, it could be drug induced also. Coming to the sleep disturbances, it would affect a number of, I think we don't have time. So use of technology in PD, you can use the wearable sensors or ambient sensors. The patients are wearing sensors and then you can track the patient. Suppose the caregivers have to attend their work. The clinicians want to know how the patient is faring for his or her day-to-day activities within the house home. So you can put wearable sensors on the patients and then track the patient's movement and make a list of what are the risk factors for the patients to fall, right? Or it could be ambient sensors which you get at home and then you can track the patients. These are some of the available technologies like gyroscopes, accelerometers, electrogoniometers. Here again you can check how the patients are faring and by walking linear, level ground walking, angulation movement when the patients are doing rotatory movement, how good is their balance and when we should start medication or other therapeutic measures to be taken for these patients. Right, so in nutshell, Parkinson's disease and Parkinsonian disorders are heterogeneous group of disorders, and Parkinsonian disorders have poor and variable response to dopa agonists, especially with levo and carbidopa. So management would require both medication as well as multidisciplinary treatment intervention, and we can give them better quality of life with this multidisciplinary approach. Thank you.
Thank you, Professor Anupam Gupta, for an in-depth presentation into Parkinson and its rehabilitation, and especially the research that you have done in Gait to reduce the activity limitations. Thank you.
Thank you.
Once more. If you have any questions on Parkinson's
And Parkinsonian disease.
and
Other
Parkinsonian
movement
disease.
disorders also, yeah.